It is actually 11:30 on the East Coast of the US of A, so it's C-Start time. Welcome everybody in the room. Welcome to our online audience. We're really happy to welcome our guest speaker today, coming all the way from the other side of the Atlantic. But before I introduce Dr. Stephanie Forkel, I want to alert you to our meeting in 2 weeks' time. On March 7th, we'll be listening to Danielle Fahey, who graduated from our very own University of South Carolina. And she'll be talking about syntactic processing in bilingual aphasia. So please, again, join us for that one. Today, however, we are joined by Stephanie Forkel. Dr. Forkel is an associate professor of psycholinguistics at the Radboud University in Nijmegen, where she also heads the clinical neuroanatomy and language research group. And she's a principal investigator and leader for the language and communication team, spanning across the Donders Institute for Brain Cognition and Behavior, the Max Planck Institute for Psycholinguistics, and the Center for Language Studies at Radboud University, Nijmegen in the Netherlands. Dr. Forkel got her PhD from King's College in London in 2013. And after that, she was a global citizen, working in a lot of places around the globe, in France, in Germany, in the UK, and also in the United States before landing in beautiful Nijmegen. Her research centers on neurovariability and its impact on cognition across different brain states, including health and disease. And by utilizing advanced neuroimaging techniques, her goal is to better understand the emergent properties of the brain's connectivity. Before I hand it over to Stephanie, everybody should check out her beautiful website, which is aptly called www.stephanieforkel.com, with a lot of information that is of interest to most of our audience. Stephanie is also the organizer and I think the principal instigator of the clinical neuroanatomy seminars, which one can find on YouTube. So she's a passionate advocate for science communication. With that, I'm going to give the floor to Dr. Stephanie Forkel for her talk, Beyond Lesions, Unlocking the Language Disconnectome for Long-Term Predictions. It's all yours, Stephanie.
Thank you very much. Thanks for the wonderful introduction. Lovely to meet you all in the room and also online, and also to see some familiar names in the group. Whoops, let me check. That works now. So as you heard today, we're going to talk about the language disconnectome and what we can learn in terms of predicting symptoms long term. And you already heard that I'm running a YouTube channel, so every now and then you will see a symbol at the bottom of the slide. And that means that even though I'm rushing over it to give you an overview of the research of the lab, there is a dedicated talk for the slides that have the YouTube symbol. Now, before we dive deep, I just want to make sure that we're all on the same page. And that means starting with anatomy. Now, there is not just one type of anatomy, there's many types of anatomy, and that is partially driven by how we look at the brain. So we can look at the surface, look at the gyri and the sulci. We can look at sectional anatomy. So that means either cutting through an actual brain or using MRI images and slicing through to see the subcortical structures, the basal ganglia, for example, but also the gray-white differentiation. We can look at the connections in the brain, and we're going to talk a lot about those in the course of the next hour. And we can obviously ask participants to perform a task or do resting state functional imaging and get the colorful blobs on the cortex. Now, I work a lot with neurosurgeons, and I learned they have a different type of anatomy on top of that, which is everything is upside down. Now, the reason it is important to be aware of this is because every type of anatomy may have terminology that differs, but they refer to similar brain areas or structures. So that is just something to be aware of when we look at the brain. Now, a simple question, usually this is quite interactive, so I can't see you at the moment. So I'm just going to give you a little bit of time to choose your number. To the question, how many lobes does the brain have? And you can see the numbers from 1 to 7. And I hope that each of you, there's usually a bit of discussion starting in the audience when I ask that question. But just choose your number for now. And I have a feeling that I may know roughly where you land on the scale. And that is that most of you probably don't choose the numbers 1, 2, 3, but the first hands would go up for 4, 5, 6, some for 7, and some even need the number 8. Now, the reason that we have this discrepancy is because the way we define the lobes has changed over time. So if we look at it, if you thought it was 4 lobes, then you are with the original definition from the 19th century, where you have the frontal, the parietal, the occipital, and the temporal lobe. Those of you who said 5 in their mind probably already included the insular lobe and have reached the 70s. And those of you who said 6 are in the 90s, including the limbic lobe. And then there is a controversy whether or not there is an additional lobe referred to as the central lobe. Now, this is important to be aware of when we discuss anatomical findings, just to make sure that we define what we classify in our papers to make sure that we agree on some of the principles in the end. Now, what is interesting is that as we disagree in the field and across the fields, so do the AI techniques that we use do as well. So a very simple method of investigating that question is that I ask Google, and Google thinks it is 4 lobes. I am quite persistent, so I asked it again a couple of months later, and Google changed its mind. And that is mainly because someone published a paper. Now, around that time, ChatGPT came about. So I obviously, as everyone else, played around with it to see how good ChatGPT's anatomy is. Turns out it is as good as you want it to be if you just keep asking it the same question. So this is literally just me hitting repeat on the same question. And the first time ChatGPT said there's 5 lobes, then I repeated the question, it said 4 lobes, and then I repeated it again, and then it started apologizing and said it is 6 lobes. So this just shows you that when it comes to anatomy, there is a disagreement in the field on the basic principles of the organization of the brain, and that is also reflected in some of the tools that we use. Now, I hope we're all on the same page now. So let's dive into the beyond the lesion aspect of this talk. So here are a couple of famous cases that I'm sure to this audience do not need an introduction. And they're all famous because they presented with a lesion and a clinical presentation that was then matched in a clinical anatomical correlational way, whereby for Phineas Gage, we had the frontal lobe. For Broca's patients, we had the posterior inferior frontal gyrus. And for patient HM on the right, we had the bilateral medial temporal lobe for memory. So it's personality, language articulation, and memory mapped onto cortical areas in a different lobe. Now, this is what a lot of our field is based on. A lot of the brain cognition or brain behavior associations that we know these days are based on initially single case observations. And they do have the validation these days. They're still driving our field. But one of the things that's quite interesting is if we take exactly the same patients, and this is work that Michel has done about 10 years ago now. So he took the lesions from these 3 famous cases, and instead of looking at the cortical damage they caused, he looked using a disconnection approach at the white matter connections that were affected given the presence of the lesion in the area they were described. And what you can see is that for Phineas Gage, even though it's quite a localized lesion in the frontal lobe, is quite an extensive disconnection that was caused by this lesion, where tracts in the frontal lobe were disconnected, but also the uncinate fasciculus that connects the frontal lobe to the anterior temporal lobe. Same when we look at Broca's patient. So the lesion, and Nina Dronkers has beautifully shown that in her MRI study of that patient, extended into the white matter behind the posterior inferior frontal gyrus. And when you look at the white matter that is running underneath that gyrus, then you can see that lesion disconnected most likely the frontal aslan tract, obviously the arcuate fasciculus, the long segment, but also the frontal parietal segment of the arcuate fasciculus, and a few more connections that you can see here. Now for patient HM, we can see that the entire limbic network was affected by the surgical lesions that were affected in his brain. Now, what this shows you is that by using the exact same input data, we can come to very different conclusions about the correlation between brain structure and clinical presentation. Now, I want to spend a little bit of time to show you how we can actually study the white matter, because there's only two methods that we have available in the human brain. And the first one is postmortem. So that is called Klingler postmortem dissection. And that is a method where you have a specimen and you go through it. I'm going to show you the steps in a minute. But that is obviously a very destructive method. Now, luckily for us, not too long ago, so we were born in the same year, in vivo tractography became available, and that now lets us study the white matter connections in the living human brain. Now, tractography, I'm happy to discuss this a little bit, has many limitations, as do all the neuroimaging methods that we have available to us, but it is the only method available where we can actually look at the white matter connections in the living human brain, and it's not destructive, which is a big advantage. So I promised I show you a little bit of how Klingler postmortem dissections work. So this is not how we do it particularly, but given the Human Tissue Act, I can't show you a recording of our own dissection. So I took this from a book, a very good book, and recommend it, references here. But what you see is that you start by pulling away or pushing away the gray matter. And in order to do that, you have to prepare the specimen in quite a laborious way, which ideally lasts about 3 months, where the brain gets frozen and thawed in a repetitive cycle. And that makes the gray matter a bit more fragile, and you can then peel it away, and you can see that you can expose those beautiful white matter connections underneath. And you can see them with the naked eye, as you can see in this example. Now, what does it take to do a Klingler postmortem dissection? Well, it takes a good specimen, as I just said, but also quite a bit of patience. It's not a quick and easy method to learn or to master. So we usually take about half a day to go lateral to medial and half a day to go medial to lateral. In the end, you end up with a very thin slab of white matter. What you can see is that the instruments you need are quite straightforward, and everyone who does Klingler postmortem dissections has their own way of preparing their spatula, for example. So some like it a bit thinner, some like it a bit thicker, personal preference, but you get used to it. And then ideally, but not necessarily, the use of a microscope is quite helpful. So you start from the surface of the brain, and as always, you begin with the anatomy. So I give you a second to identify a couple of structures on this brain. As you can see, it's not a textbook brain, even though this brain had no brain pathology at the time of death. So this is just normal variability that we can see. And if I now give you a couple of pointers here, so we have the Sylvian fissure, or the lateral fissure, underneath the superior temporal gyrus and the superior temporal sulcus. This is where we usually start in the depth of the sulcus to peel away the cortex, and then you go around and do a C shape around the entire brain, and there's the big and the small C along the sulci. And when you do that, you end up with the specimen that looks like this. Now, what you can already appreciate is that finding your way around gets harder and harder as you go further. So I'm just going to give you a couple of pointers of where we are. Obviously, we can still see the lateral fissure quite nicely, but the rest of the landmarks are getting a little bit harder to see. Now, in terms of the white matter that you can see first, the white matter is nicely layered in the brain. So the first one that we can see is the arcuate fasciculus that is arching around the sylvian fissure, and we can see some U-shaped fibers that interconnect neighboring gyri. Now, in the next step, I'm going to cut the arcuate fasciculus and go one step deeper, and now you can see that we exposed the ventral network, as it's often referred to, that includes the inferior fronto-occipital fasciculus, the uncinate fasciculus. We can see the beginning of the internal capsule, and then also towards the occipital lobe, you can see quite nicely in the specimen the vertical occipital fasciculus. Now, we do this every year in a white matter dissection course, and the beautiful advantage that that gives you is that you see at least 15 brains in one go. And what you can appreciate is that when you look at the brains, they all look different. So here's one example of two randomly chosen brains. And if we just look at the lateral fissure and the supramarginal gyrus that sits at the end of it, you can see that the two right hemispheres I'm showing you here have quite a degree of variability, both in the fissure as in the gyrus. Now, this is not unheard of or uncommon, and I'm going to show you a couple more examples. So you may have heard about the inverted omega, the hand knob area. So again, giving you a second to find your way around. We're looking from the top at the brain here, and I'm just going to show you where the central sulcus is in both examples here. And you can already appreciate that there's variability between the two brains, but also between the left and the right hemisphere. And if we look at the hand knob area, or the classically called inverted omega, you can see that in the far left, it is actually a textbook inverted omega, but that is not the case for both hemisphere or between people. Now, another beautiful example that I was lucky enough to get from our colleague Pascal Bellin in France is the anatomy of the superior temporal sulcus here. So you can appreciate the variability in the structure, but also he mapped the voice selective areas in the auditory cortex. So you can see that there is a huge degree of structural variability, but also a huge degree of functional variability. Now, the auditory cortex is not the only primary cortex that shows such a degree of variability. If we look at the visual cortex, for example, using a different method, so this is cytoarchitectonic mapping now, you can see that there's quite a degree of variability between the left and the right hemisphere in the same brain, but also across people. And similarly, we see that also for the areas 44 and 45 in the posterior inferior frontal gyrus. Now, I could go on and give you many, many more examples of this. So this is just to say that this is not the exception, but the norm. And that led Karl Zilles and Katrin Ammons to conclude that variability is not noise, but rather that it is actually an invaluable principle in the brain to understand the principles of brain evolution and development, and for interpreting statistical maps in task-based functional imaging studies. Now, we don't account for variability in neuroimaging as much as we probably should, and there's various reasons for it, and the field is moving more and more into capturing this variability and trying to statistically account for it. But I want to give you a toy example that hopefully makes it a bit more tangible of what the problem is when we look at group studies rather than variability. So here is a slide of a couple of women. Anyone in the room or online knows who these women are? No one brave enough to speak up. Fair enough. So what you see here is an overview of all the women who won a Nobel Prize for physiology and medicine. And every year I'm hoping to update it, but it hasn't happened this year. So we'll see if we get lucky next year. But yeah, so these are all the women that won the Nobel Prize. And I asked my student to create an average face, so we know what you have to look for or look like when you want to win the Nobel Prize as a woman. And here we go. This is the average face. Now, what you can see is a couple of things here. Number one is the algorithm worked. We have an average face, fantastic. 2 eyes, a nose, a mouth, roughly in the same place. So that is a good sanity check. But what we can also see is that the face in the middle doesn't actually look like any of the women around it, nor do any of the individual women around it look like the average face in the middle. Now, while this is extremely obvious when we look at a face, it is a lot less obvious when we look at the average brain. So this is the MNI template, and we can see areas here that are very sharp and crisp. So for example, the caudate or the basal ganglia, they have sharp boundaries. And that means that there is less variability. So we tend to be more alike, whereas the areas where we tend to be more variable, when you look, for example, at the temporal cortex here, the image becomes a bit more blurry. Now, I've already shown you examples of the variability in the cortex. So this is the inverted omega example again. But the same variability or the same degree of variability can also be seen in the white matter. So here are 2 randomly drawn healthy participants from a local data set here in Nijmegen. And we mapped the extended language network. And we can see that when we look at the uncinate, for example, in the top image, it's barely visible, whereas in the bottom image, it's extremely prominent. And similarly, when we look at the anterior segment of the arcuate, for example, there's quite a degree of variability. Now, these are obviously hand-picked examples. So we wanted to know what that looks like on a group level. And this is work that Paula Croxon was leading on, where we mapped the variability of the white matter across the population. And what we can see is that variability is not homogeneous across the brain. So you see this beautiful gradient here, where areas that are deeper inside the brain, also the more older parts of the brain, have a colder color, and that means there is less variability, or if you flip it around, there's more similarity between us. And as we go out, there is more and more variability. Now, this is important for various reasons. This is important, for example, if we use an atlas. So if you use an atlas in the center of the brain, it's fine because we're more alike, but as you go out to the surface of the brain, it becomes more and more difficult to rely on an atlas approach. And this is in a healthy brain, and obviously in a pathological brain, this is exaggerated. So here I'm giving you one example of one of our tumor patients. So in green, you see the brain tumor. And we wanted to know where the corticospinal tract is. So we did a in vivo dissection using tractography. That's where you see in blue. And you can nicely see the fanning of the corticospinal tract, and then it consolidates towards the internal capsule. Now, when we used an atlas and plotted the atlas onto the patient brain, what you can see is in red, the outline here, that the atlas would have completely missed where the actual corticospinal tract is. So this is quite important to be aware of, especially in a clinical setting. Now, as I mentioned, we only have those 2 methods available to us to look at the white matter of the brain, but there's many other methods available in other species. And when you apply them, you can see that our understanding of other behavioral and cognitive systems, like the visual system here or the auditory system, are extremely detailed. So here, every single box is a cortical area and every line is a connection. And you can see, especially for the visual system, that is a very dense plot. Now, when you open most of the textbooks to look at what language looks like in the brain, then most of the textbooks sadly still have this rather outdated image with two cortical areas and one white matter connection in between. Now, tractography has done a fantastic job in mapping a more extensive white matter network, beginning with a validation of the original description. So here on the far left, you see the arcuate fasciculus, the long segment as it's called, or the frontal temporal connection, so the direct connection between the frontal and the temporal cortices. And then the early 2000s, Marco Catani used tractography to show this indirect segment that relays in the inferior parietal lobe. And these two branches are either referred to as anterior and posterior segment or horizontal and vertical connections. Now, since the early 2000s, many more connections have been implicated to be relevant for language functions, and that is through other means of testing the function, for example, during brain surgery using direct cortical stimulation. Now, what we did recently is we dissected the extended language network in two large data sets, and then we were interested in the cortical projections of these white matter tracts. And when you do that, number one is that these tracts are all bilateral. So we find them in the left and the right hemisphere. And when you project them onto the cortex, you can see that, again, there is a degree of variability. So you have some hotspot areas where they very reliably project to, shown in darker colors here, so in red, and areas where there is slightly more variability between people. Sorry. Now, what you can also see is that all the white matter that has been associated with various language processes is projecting onto most of the cortex in the left and the right hemisphere. So not just the classical definitions of Broca's and Wernicke's aphasia area. And that is so much so that in the beginning, we thought we just plot them all on one brain. And it was so busy that we couldn't do that. So we had to split it up for each segment in the language network. Now, as I mentioned, they are bilateral tracts. So we were also interested in looking at the asymmetry. And what you can see is that there is no consistent pattern of asymmetry across the language network. So some tracts tend to be more right lateralized, others are more bilateral, and others, again, are more left lateralized. And what we were also interested in, and this is work done by Lilith Dolyan in the lab, is to look at the variability overall. So not just per tract, but also which side of the brain, when it comes to the language network, is actually more variable, and is that specific to certain tracts. So this is work that Lilith did, and this is the result of it. So what you see here is that overall, there is a difference between the left and the right hemisphere. So the left hemisphere tends to be more variable than the right. And also this variability can be measured in a tract-specific way. Now, Peter Haggard and I recently tried to put that all together and come up with a new model, anatomically based, where all these tracts that you can see here have been implicated to be involved in some kind of language processing. And here we're applying a very broad definition of language in the brain. So the vertical occipital fasciculus, for example, in green towards the right of the brain, has been implicated in reading, the arcuate in learning a new language and motor phonemic mapping, the frontal Aslan tract in initiation and sequencing. So there is many tracts that have been implicated for some or another language process. And on the right, you see pretty much the same image, but we try to show the anatomical areas that are involved. So again, the boxes are the cortical areas. Then in pink, you have the subcortical structures that have been implicated. And then the lines are all the white matter connections that you see in the middle here of the image. So this is the anatomical part. We now have a fairly good understanding of the extended network of language in the brain. And we know that there is a huge degree of variability, both at the cortical level, but also the subcortical level. And then the next question is, does it matter? Is it relevant that we are actually different when it comes to our brains? So we embarked on a meta-analysis of 326 studies that took us quite a while to review, but we learned a great deal. And the first thing that we learned is that most of what we know about the function of the white matter, we actually know from clinical populations. So the majority of studies were conducted in neurological and neurosurgical patients, and about 29% in psychiatric patients and only 25% in healthy participants. The other thing that we learned is that there are certain tracts that are superstars in the field, like the corticospinal tract, and other tracts that are quite neglected, like the accumbofrontal pathway, for example. Now, there is obvious reasons why you have this discrepancy, and that relates back to how prominent these tracts are. So the corticospinal tract is obviously much larger than the accumbofrontal pathway, and therefore also slightly easier to dissect. Now, the other thing that we learned is that these tracts tend to be prominent in one field more than the other. So the corticospinal tract is extremely prominent in neurology and neurosurgery, for obvious reasons, because neurosurgeons obviously want to try and avoid causing any motor deficits. So they always need to know where the corticospinal tract is. But if we look at the inferior longitudinal fasciculus, for example, that is primarily studied in healthy participants, especially when it comes to reading. Now, as a next step, what we did is we looked at the functional correlations for all of the tracts that we looked at, and in total there was 36 tracts, I believe. So there's quite a substantial supplementary material in this paper, but I'm just going to zoom in to my favorite tracts, which are the arcuates. And what we can see is that the arcuate does correlate reliably with language, but not exclusively. So you can also see correlations with sleep, memory, executive functions, auditory functions, attention, and motor functions. And that is a pattern that we have seen pretty much across all the tracts that we looked at. So there is no one tract, one function association, which again brings us back to the idea of localizationism in the brain. So initially stating, when we look at the famous cases that I opened with, that one cortical area is involved in one function, and we're moving away from that on the cortical level. And we started in a similar space with the white matter, where one tract, like the arcuate, is the language tract. But in fact, when we look at it, it looks like that the white matter is recruited for multiple functions, but partially specialized in certain functions. So at this point, we know that we are different in terms of our anatomy. We know that this is also relevant when it comes to mapping functions. And now the question was if we can use this information in a clinically meaningful way. So what we did in this particular study is we recruited acute stroke patients who had a lesion to the left hemisphere, and we recruited them in the acute stage for imaging and neuropsychological assessments. And then we followed them up 6 months and also a year after symptom onset. And what you see plotted here is on the x-axis, the size of the arcuate fasciculus in the healthy right hemisphere. So the lesion was on the left, and we looked at the arcuate on the right, plotted against the recovery 6 months after symptom onset. Now, the blue box on top is where you are above the cutoff line. So these 3 patients that you can see there are officially recovered back to normal 6 months after symptom onset. And I'm just going to highlight 3 patients for you here. So patient number 1, you can see on the far left, didn't really recover well 6 months after symptom onset. And when we look at the arcuate fasciculus in the right hemisphere, it is rather thin and small. And as we go up to patient number 3, you can see that the arcuate is very thick and strong in patient number 3. Now, what is interesting about this study is that when you only look at clinical and demographic data, we can predict about, depending on the studies you're looking at, between 30 to 40% of the variance in recovery. Now, by simply adding the variability in anatomy in the arcuate fasciculus in this case, we can nearly double that explained variance. So that is quite a strong indication that looking and accounting for variability is actually quite useful in a clinical setting. Now, another study and type of aphasia in particular that we were interested in was conduction aphasia. So conduction aphasia is characterized by fluent articulation, intact comprehension, but one of the things that doesn't work, for example, is repeating what you heard. So the information that's processed in the auditory cortex cannot be sent towards the frontal lobe for articulation. And this is one of the classical disconnection syndromes. Disconnection because it was hypothesized that the inferior frontal gyrus is intact, that the superior temporal gyrus is intact, but the communication between the two, particularly via the arcuate fasciculus, is interrupted. Now, with the emergence of CT and MRI imaging, that narrative shifted slightly towards the inferior parietal lobe, as studies showed that you can have a lesion to the inferior parietal lobe that is not affecting the arcuate fasciculus and still have a clinical presentation of conduction aphasia. So we wanted to look at that in a multimodal imaging paradigm. So we had tractography data, but also cortical morphometry data in patients with primary progressive aphasia. And this is the cohort from the Chicago team. And we looked at the the atrophy in classical language areas and also the 3 segments of the arcuate fasciculus. Now, the first thing that we saw, quite to our surprise, is that the size of the arcuate fasciculus, so the classical long segment, did not correlate with repetition deficits at all, but the indirect segments, so the anterior and posterior segments, did correlate with repetition deficits. When we looked at the cortical level, across all these regions that you can see on the top here, the only one that survived multiple comparison correction was in fact the posterior supramarginal gyrus, so the inferior parietal lobule. Now, what that meant is that after 150 years of the arcuate fasciculus, or disconnection of the arcuate fasciculus leading to conduction aphasia, we took the arcuate fasciculus out of the equation and just kept the indirect segment and proposed a new model whereby lesions can occur anywhere in this network, including the inferior frontal gyrus, the inferior parietal, or the temporal, and the connections in between to cause repetition deficits. Now, obviously, depending on where in this network the lesion will occur, the flavor of the repetition deficit will be slightly different. Now, a couple of years ago, I presented this at a conference, and one of the neurosurgeons in the audience was extremely excited about it because he actually observed a similar pattern in his patients when he stimulated the inferior parietal lobe, leading to repetition deficits. So I'm going to show you the video very briefly, and I hope the audio works. But for those of you who are a bit squeamish, if you want to close your eyes, close your ears for about a minute, now's the time to do so, and then just get someone next to you to pinch you when it's over. For everyone else, what you're going to see in a second is a neurosurgical intervention where they try to map language deficits across the cortex. And as they stimulate the cortical areas, they ask the patient to repeat what they heard. So here we go.
Hospital. Coat. Today is a nice day. I like watching movies. Of course, Caroline. Okay, let's try again.
She's fluently having a problem there.
Yeah. No ifs, ands, or buts.
Okay.
So actually, when you put
That's on 4, yes?
4, just write repetition.
That's DCS, yeah?
Yes. House. Hospital. Okay, let's try again. Coat. Today is a nice day. She's a bit eccentric there.
Okay, so what you can see here, obviously finding your way around anatomically is a bit difficult, but when they stimulated the inferior parietal lobe, that patient quite consistently had repetition deficits. Now, what I've shown you so far is that we can look at individual brains and in particular health individual patients and dissect the white matter that we're interested in. But we can also take a different approach that is known as the disconnectome, where you delineate the lesion, bring it into MNI, so a standard space, and then plot that lesion onto X numbers of healthy connectomes or tractograms. So these are taken from data sets like the Human Connectome Project. And as you bring the lesion into each and every single one of these normative connectomes, what you then can see is the estimated reconstruction of the streamlines that are affected by the lesion. Now we can then binarize this per individual connectome and come up with a disconnectome map that gives you the probability of these white matter connections to be affected by a given lesion. Now this is particularly interesting to do when you have patient data where you don't have the diffusion weighted imaging available, so you can't do tractography in the individual patient, but you always will have a CT or a T1 scan that you can use for this disconnectome analysis. Now we applied this to data of conduction aphasia. So first taking all the lesions and plotting the lesions to see where the heat map indicates the area of most overlay. And not surprisingly, we see the posterior temporal inferior parietal region here. And when we do the disconnectome, however, we can see that the white matter that is affected is extending far beyond that particular region, even into the right hemisphere in quite a few of these patients. Now, this is an example dedicated to one clinical presentation, but Leah Tolozzi recently did this beautiful work where she took over 1,000 stroke patient lesions and mapped the disconnection of all of them, and then used an embedding dimensional reduction approach to cluster the lesions or the connections, disconnection profiles for every stroke patient. So every dot you see here is an individual stroke patient, and the pattern of disconnections here are clustered based on similarity. So if they're closer together, they tend to be more alike, and if they're further apart, they tend to be more distant. Now we were then able to combine this embedded space with neuropsychological data that was provided by Maurizio Corbetta and map the different neuropsychological assessments in the same space. And this allows us to relate the pattern of disconnection caused by a lesion with the neuropsychological assessment of the neuropsychological cognitive behavioral battery that was applied, and in total there was over 80 assessments available. So this is quite a substantial data set, and what this allowed us to do is to predict long-term recovery, meaning that given the lesion of a patient, you can map the disconnection, the pattern of disconnection, you project that into this embedding space, and that allows you to get a prediction of where that patient most likely will be in a year's time. Now, all of this we made available on our website called the Disconnectome Symptom Discoverer, and the video shows you how it works. So you see the space that I've just explained to you, where you have the different dimensions, and every single dot is one of the patients. And then you have, for every test available in the battery, you have a description of how it was assessed and what you have. And it's quite, as I mentioned, a substantive list of neuropsychological assessments. Now, on the website, you can just upload a lesion mask. It will calculate the disconnection, so that all the white matter that is most likely affected by this lesion. And then you let it run. And this video is in real time, so this is how long it takes. So it's quite fast. It will give you the prediction of where that patient is likely going to be in about a year's time across all these neuropsychological scores, and you can just export this as a Excel file and take that further for your statistics. Now, this approach was recently validated out of sample by Tom Hope and Kathy Price from UCL that used the same approach on their independent PLORAS data to predict language recovery long term. Now, the other thing that we can do with this approach is we can actually map a neuropsychological white matter atlas. So the map in the middle is probably slightly unfamiliar to most of you, but it's a cross section through the brain. So it's an axial slide looked at from the top. And in the middle on the top, for example, you see the corpus callosum. And then for each of these connections, you have the most prominent association of the neuropsychological scores. And this is a dynamic map. So I'm obviously just showing you one slab of the atlas, but you can scroll through and see how these networks change throughout the brain. Now, if we put this all together, which is what Michelle and I recently did, is leading us to an understanding of language being an emergent property of the connected brain. And I'm going to spend the rest of the time that I have to slightly disentangle what we mean by that. So language is by no means the only emergent property in the brain, but probably one of the most elegant ones that we have. Now, what we did in this review is that we looked at the classical neurobiological model, where you have the posterior inferior frontal gyrus, the temporal gyrus, and also the inferior parietal lobe. And you have this association, a classical localizationist view of one region, one function. Now, when you do that model with 3 regions, the computational flexibility that this model provides is quite limited. So our complex and dynamic interaction style that we have when we use language wouldn't really be explained by just having those 3 regions available. Similarly, when we connected them in the early 2000 model, where you have the direct segment of the arcuate and then the indirect route, again, the flexibility in the system is too limited to explain language processing as we know it. So what we proposed, and as you can see in this toy model, it's not the proper anatomy of the model that we think it is, but we're still in the process of mapping the actual anatomy to it, is that language is an integrative function of the brain, or emergent property of the brain, whereby cortical regions and white matter connections get dynamically recruited for different linguistic processes as they are needed, and together they produce what we refer to as language. Now, I still find this quite abstract, so I came up again with a toy example that hopefully makes this slightly more tangible. And the best example that I could find is this one. So if you ask me where language is in the brain, that question is equally hard to answer than asking where music is in the orchestra, because music is not in the individual musician, it's not in the conductor, it's not in the instrument, it's not in the notes. It's in all of them coming together in a timely, organized fashion that music emerges. And this is similar to what I believe language in the brain is like. And with that, I would like to thank my team and look forward to your questions. Still there?
Yes. Hello, Stephanie. I'm so sorry. I was just late, so you didn't hear the applause you got from our room. But I think if you have your cam on, you could, I don't know what kind of view you have, you would be able to see our room. So
I see the room, yes.
Thank you so much for your talk. Let's start with questions from the room. While people online, please feel free to start typing your questions.
Thank you, Stephanie. This is wonderful as always, and very interesting to especially see the neuropsychological aspects of all of this. So I appreciate the point you make about individual variability, right? And your example of the average face not reflecting any of the individuals, but it actually does, depending on what you're interested in, right? So the average face has two eyes, it has a nose, it has a mouth, and those are very important essential functions of a face, to produce speech or to breathe or to, look at people, etc. Right? So, I mean, I think, isn't it? So I guess the question is like, how, relevant is that critique if you're trying to understand certain essential functions that are shared? Like if you're looking at the brain, yes, of course, there's variability, but how many people lack a superior temporal gyrus, right? Or how many people lack an arcofasciculus altogether? And so I guess my question, I want to push a little bit on that is there and obviously the individual variability is relevant for things like recovery, which you show very well. But if you're trying to understand the basic architecture or functionality, is that a problem to ignore that variability?
Very good question. And obviously, I have thought about this quite a bit. And the answer is it depends on what we look at in terms of the processes and what the aim is. If we want to have a general understanding of roughly where things happen in the brain, then you can look at the group level. There's absolutely nothing wrong with that. And then the inter-individual variability doesn't matter as much. But what we see is that a lot of the models that we have available are based on, for example, fMRI average data. And when we bring that back to the individual, especially in the clinical setting, then these maps don't inform us where language necessarily is. And while if we do a healthy control student study where we just want to see where certain processes light up, it doesn't matter to get it wrong within like margin of error. But if you come to a neurosurgeon, then you better get it right. So it depends on what we're interested in and what the aim of knowing is in the end. But depending on where you are, you can use the full spectrum of the methods available, and they all have their merit and their limitations, obviously.
A technical question. You showed kind of a standard tractography where you imported or overlaid like the lesion on top of the maps. Is that from a specific tool that you can access, or like where is that found?
So that's on the bcblab.com website or on my website under the open data, I think the writer is called. You can find the toolbox. It's part of the BCB toolkit. It's called the Disconnectome maps. And the data, so the individual connectomes that I've shown are taken from the Human Connectome project, and they're also individually available on the website. So all of this is openly and publicly available.
So yeah, thanks. I have more questions. I feel like I keep talking about this for hours, so this is a testament to how interesting your talk is. But how do you distinguish between complex and emergent, right? So you talk about language as an emergent function, but why not just say it's complex? There are multiple underlying components. You have to integrate them all together to understand the whole picture. What makes it emergent as opposed to simply complex?
Very good question. There's a lot of people trying to figure this out at the moment. The difference that I would see as the most prominent difference is that if it's complex, we could potentially decode it and explain the variance as we go along. Oops, you're moving. But the emergence is in the fact that we can't map the emergent function per se. It's in the interaction of processes. And that to me is the difference. If it was complex, we could, at some point with enough data, time and resources and sophisticated tools, we could map the individual components of a complex function, but the emergent function is in the interaction and therefore a lot harder to capture.
Thanks, Stephanie. I want to go to some of the online questions to give them a chance as well. We got a question from Peter Pressman. Given the association of repetition, the phonological loop, and working memory, can you please further discuss the specificity of the described conduction evasion network for language versus working memory more generally?
Yeah, so as I said, there's different linguistic processes that have been mapped, and the classical study that Marco has done, for example, looking at the arcuate fasciculus as a language pathway, was using the California verbal learning test, which has this verbal working memory component to it that was mapped onto the long segment. And we're still in the process of really disentangling all the individual segments of the arcuate fasciculus, but also the extended white matter network in terms of which processes rely on which connections. So the concrete answer is still to be seen, but we are getting closer to mapping a more comprehensive functional structural network when it comes to the white matter.
Great, thank you very much. And we have a question from Dorian Pustina, who actually also recognized one of your Nobel Prize winners. So he was actually able to.
Fantastic.
Excellent work, Stephanie. Have you noticed any discrepancy between the virtual tract reconstructions and the tracts found in dissections in terms of presence or consistency?
Very good question. It's a bit a chicken and an egg question. So when we started out with tractography, Klingler postmortem dissection was seen as the gold standard to validate the white matter connections that we see in the living human brain using tractography. And what we have learned over the years is that postmortem dissections and in vivo tractography by and large suffer similar limitations in their methodology. So to give you one example, and you've seen that in the beginning of the talk, if you want to dissect out the white matter using Klingler postmortem dissection, you start off by taking away the cortex and you go layer by layer deeper into the brain to expose the white matter underneath. Now that means that by virtue of the method, it's very hard to say where the white matter is terminating. Similarly with tractography, the closer you get to the cortex, the harder it is to track the streamlines. Now this is improving as we go along on both accounts. So in the white matter world, there is now beautiful work done where you get a digital reconstruction and you take images at every step of the dissection. And then afterwards you can reconstruct it in 3D and try to scroll through and see where the white matter most likely terminated in the cortex. And also on the in vivo side, we're getting closer and closer to cortical areas. But there are several limitations that make it difficult to cross-validate the two methods. Now, in terms of the difference that we see, it's limited in a sense that if you look at the core of the tract, you find a similar reconstruction in postmortem and in vivo dissections. But when we look at the arcuate, for example, if you use a DTI algorithm compared to a spherical convolution algorithm, where that tract projects to varies a great deal. So with classical DTI, it goes to the ventropremotor and the posterior inferior frontal gyrus. With a more advanced tractography algorithm, it goes all the way nearly to the frontal pole. Now, there is no way in knowing where those connections actually terminate, if it is the tractography based on DTI or SD, or in fact somewhere in between. We can't tell based from tractography, but also Klingler postmortem dissection doesn't help us to disentangle that. So the similarity in the core is given, but as we go closer to the cortical regions, it becomes harder and harder to be sure that you can validate it. Now, another thing to bear in mind is that there's different types of tractography. So some use a methods-driven approach, and others, like the ones that we are using, are actually validated for the last 20 years on postmortem dissection. So they're engineered to show you reliably what we know from postmortem dissections.
Thank you very much. And we have a question from Kyriaki Neofitou. Following up on the response to Will's last question, emergent versus complex, is this a suggestion then that we should not be ascribing any more specific processes to specific cortical regions?
Good question. So as with many things, the truth is probably somewhere in between. Certainly, it's not a one function, one cortical region association across the entire brain. There are certainly cortical areas that are specialized or primarily serving a given function, but doesn't apply to the entire brain. Now, on the flip side, I'm not saying let's get rid of all cortical functional association and every part of the brain can just chip in and they're all equal in their functioning and relevance. That's not the case. We know there are certain patterns, and for example, depending on where a lesion roughly occurs in the brain will have an impact on the types of aphasias that we can see. So yeah, the truth is somewhere in the middle, that not every cortical area is engineered towards one function, but also it's not the entire brain that is completely flexible and plastic and can do everything.
Thank you, Stephanie. I think that's a good note on which to end our your talk and our discussion for today. Thank you so much. And thanks to the online audience for attending. And we hope to see you next time.
Thank you. Bye.